Team, hi. I can't finish the intro because Prof. Rez has something very important to show you. Prof.
Good,
Rez.
good morning to all my YouTube family out there. I love you guys. Robbie and I are we're gonna launch something for you, and I'm gonna show it to you right now. But in order to do this, you have to go incognito. So after you watch our YouTube video, uh, going forward, you'll get a 5-question quiz just to
Mhm.
test the knowledge that you learned from the YouTube video. And let me just show you what that might look like. So this was our video on anemia causing shortness of breath. And basically, when you go to solve this quiz, it will read the question out to you.
Wow.
This is a long question, but that's okay. Cool. And then you
That's
get a little, dude, it's insane. And let's just say this, only 5, even 3 respond. Let me show you.
wow. You're very smart. So far, so good, Prof. Rez. I'm worried about what's coming next. Ah, wrong.
But the cool thing about this is that, and then this is really cool.
Yeah. Which of them? So you're saying, Prof. Rez, that the person doing this will be able to hear the question?
Yeah, they're going to hear the question.
Right.
Then it just allows you to just test the knowledge you acquired from the video. And it's short, 5 questions. And it's all, Robbie, it's all generated through AI. So all I have to do is
So
upload the
cool.
transcript or just share the YouTube link. Just
Wow.
share the YouTube link. And then
Incredible.
it generates, it can be 5 questions, it can be multiple choices. It's all based on our teaching. So it's not like it's generating random questions.
That's so cool. How much does it cost, Prof. Rez?
I haven't looked at the. Oh, it's actually. I think it's like $70 a year.
Wow. Wait, cost you or cost the user?
Oh no, it will cost CP Solvents.
I see. So
So
for the
it'll cost
user, Prof. Rez,
us.
I'm trying to plug your product here. What is the cost the user? Who cares what it costs you? Zero. Amazing.
So what
That's
do
so
you think
cool.
about that? I know we're doing a
That's
little bit like as if we're in private. Do you approve of it,
yeah, it looks
or
amazing. That's so cool.
we can even use it for podcast episodes? Like if you wanted to ever make the CME or whatever,
Yeah.
this is the way to do it. Like you just plug it in, it generates a question with the answers, and you just share the link. And the user doesn't even have to put in their name. They don't have to worry about anyone seeing how many questions they get wrong.
Prof. Rez, this is so cool because I'm realizing I think this is the first time that this, and I'll explain what this means, is being recorded for people to see. So whether or not you all realize it, 6 years into the inception of CP solvers, you're seeing the very fuel behind the creation of CP solvers before you, which is the creativity and innovative ability of this human being. And it's the first time, these are, as Prof. Raj just said, he's asking if it's okay for us to share. These are the conversations that I'm privy to behind the scenes where this guy just randomly calls me and without any forewarning just jumps into his incredible creativity. And it's so cool.
But you know how I started the day though? I was at the
Yeah.
coffee shop. I took a picture of Nar and I tried to make it into a video so I
Oh
can
my
send it
God.
to you and Kara.
Oh my
But it kept
gosh.
saying error, error, and I gave up on it.
Yeah, you can't capture Nara's beauty on in digital form, Prof. Rez. It's impossible. In fact, I mean, look, how is this? We're just gonna turn this into an RLR session, private, huh? Look at this guy. He's built a fort and he's all wet. So anyway, Prof. Rez, what do you say we nerd out for the remaining 52 minutes?
Yes, I would love that. And it's your turn to tackle the first aliquot. And I hear that Zachariah is going to be presenting today, which
100%.
it doesn't matter which Zachariah, there's two that are part of CP solvers. And to me and Robbie, there's only two in the entire world of Zachariah. But either one who presents is going to be a difficult case. Who's scribing and who's teaching?
Kritika,
Hello everyone. I hope everyone is having a good day. Happy to do this currently.
Kritika, you made my day by turning your video on today. I don't know if you know that or not. I was very grateful for you. Thank you very much for doing that. All right, Eugene, you're doing teaching points, right?
Yeah. Hello, everyone. I'm Eugene. I'll be doing teaching points.
Guys, I envy you to strive to the background level that Eugene has. Kudos to you. I'm trying, but it looks really, really good, Eugene. Thank you for turning your video on as well. And yes, last but not least, Prof. Rez, it's the OG Zachariah G, who's presenting today. I'll hand the mic to you.
Hi, everyone. I'm Zachariah G. Thank you, Ravi, for emphasizing that I'm the OG Zachariah, as the other one is in the audience as well. And I didn't know that. Yeah, but I'm very, very excited for this case. It's the first of many from my time in ICU over the last 5 months. And yeah, I've been thinking about it a lot over the last month or so. So let's go.
Zachariah E, as from the non-OGR, because we all know who the OGR is. I feel your pain, but it's okay. We just have to accept that sometimes being second is best, as my sister used to say. All right, take it away, my friend.
Just gonna wait for the whiteboard to come up. Okay, I'm going to take you to a slow day in the ICU about a month ago, where I saw a 27-year-old female in the morning who had sinus bradycardia and hypotension. And I'm going to stop there and actually share my screen. You'll have to excuse my relatively rudimentary echo skills. I wish I'd taken a bit more time to get a better video, but this is what I saw. I'll stop and date one more time.
Unfortunately, OG, I can't help you with this echo interpretation whatsoever. Prof. Rez, do you have any thoughts?
You want me to embarrass myself?
Yeah, of course. That's why I asked you.
So it seems like the LV is quite dilated, if I'm not mistaken. Is that right, Zachary? To me?
Sorry, I didn't catch that.
I said, is it the chamber, the left ventricle? Is it quite dilated, or is that the right ventricle?
So this is a peristernal long axis, and the patient had sinus bradycardia and hypotension. So we performed this sort of immediate echo. So just a 7-second clip that I wanted to show off her left ventricle. And the last thing I wanted to say before the discussion was that she was immediately bolused with adrenaline and then started on adrenaline, and nothing happened to her heart rate with that. And I'll stop there.
Yeah, but Professor, maybe I can just reflect on the medical elements because honestly, Zachariah, my POCUS skills are abysmal. In fact, it's so funny with watching people become more and more enthusiastic about POCUS. I have developed a childlike reaction where I've receded the other way. That's unfortunately something I have to work on. So I'll definitely have to rely on you or somebody else to interpret that echo. But I think that the clinical scenario is actually very powerful here because I think if you had asked me about 5 or 6 years ago, I think that I would easily jump to the conclusion that the patient's hypotension is from the sinus bradycardia. And I think anytime that you see a low heart rate and you see a low blood pressure, it's very easy to connect the arrows by suggesting that the low heart rate is causing the low blood pressure. And that is 100% true if you get any rhythm that is slow that is not sinus bradycardia. However, when you remind yourself that elite athletes are able to mount a blood pressure in the 200s when there's sinus bradycardia, you realize that you have to find out what's different between that elite athlete, say Prof. Rez, and this patient. So, Prof. Rez, when he's in elite shape, his heart rate is sinus brady. Why isn't he hypotensive, but why is this person hypotensive is a very, very important thing to reflect. And I will tell you the shortcut isn't to disregard the value of sinus bradycardia. The truth is that most people, when they're hypotensive, are not sinus brady. So herein lies the paradox. Sinus bradycardia in many healthy people is actually a sign of their health, but also many people who are hypotensive do not have sinus bradycardia. So what do we do? How do we reconcile this tension? And I think the answer is to realize that sinus bradycardia may not be causing directly the hypotension, but it is telling you, knock, knock, there's something wrong with the heart. And the rhythm is a clue that there is an underlying disease mediating both the bradycardia and the hypotension. So how do we connect the arrows reflexively? Don't start with sinus brady causing hypotension. Use the sinus bradycardia as a clue that there is something lurking underneath those two things, drawing and connecting the arrows to both of them. An example, beta blocker overdose. We commonly talk about how beta blocker overdose causes both sinus bradycardia and hypotension. So for me, what does this do? 75% of all hypotension in the United States is distributive in nature. The presence of sinus bradycardia pushes me to prioritize cardiogenic causes much earlier than the base rate. It does not push me to falsely equate the bradycardia as the cause of hypotension. So this is why I think looking very, very closely at the echocardiogram is a great part to analyze cardiogenic shock, but this is how I'm working through cardiogenic shock. And I think there's two elements for Prof. Rez to help us with is, of course, reflect on this, but to reflect on the fact that this hypotension seems to be refractory to epinephrine, and of course, any insight that Zachariah or anybody else can give us a clue about what's going on structurally. Thoughts, Prof. Rez?
Man, I love the discussion that you started with. And yeah, I really have nothing else to add. This is a scary situation. Young person and cardiovascular collapse. Got to move quickly.
Absolutely amazing. So I think just to answer the first question, my echo skills are quite rudimentary, but what it looked like to us in that moment was that the patient's LV, in addition to her being bradycardic, her left ventricle was not contracting well at all, and she seemed to have a small pericardial effusion. So onto aliquot 2, nothing at all happened to her heart rate and her blood pressure when she was started on adrenaline. And we bolused her with atropine, which made a marked difference in terms of both her heart rate and her blood pressure. And actually about 1 hour later, her heart rate was in the 140s and her blood pressure was normal. Onto some further history. So as is often the case when you're seeing a patient for the first time in the ICU, she'd been admitted approximately 2 days prior and then intubated in casualty due to a low GCS. We didn't have much more history at the time, besides that she'd been unwell, not really eating over the last 6 months, and just generally feeling weak. With regards to her past medical history, she's HIV positive. And in terms of her medications, she'd recently possibly seen an alternative medical practitioner, but reportedly had taken no medications. And I'll stop there.
Yeah, Zachariah, it's really interesting. You know, I'm trying to reconcile in my mind why she wouldn't respond to neuroepinephrine, but responds to atropine. And just to ask you a quick question, when you gave the atropine, you saw both an improvement in the heart rate and the blood pressure. Is that correct?
Correct.
So
Instantaneously, pretty much.
Instantaneously. That's really helpful. I think what I'd like to show you guys, I think this is going to be helpful to bring up our schema. I think it's actually on our RLR website. One second here. Because what this is doing for me, when someone is getting better, like, you know, Robbie had raised the question of whether the blood pressure and heart rate were both going down because of a unifying cause, or whether the heart rate was causing the hypotension. And so what I'd like to share with you, and I think it's going to be really helpful for many of you watching, is our figure here on our RLR AP Solvers website. And, you know, I haven't seen too many patients heart that have a slow heart rate, Zachariah, but I would imagine it wouldn't be contracting much. I would be really interested if you have an echo to follow up or a focus to show the contractility with the increase in heart rate. But ultimately, let's go to a simple equation. The blood pressure is equal to what? The cardiac output times systemic vascular resistance. What is the cardiac output equal to? Heart rate times stroke volume. So if you either have a very low SVR, a very low stroke volume, or a low heart rate, your blood pressure will drop. And Robbie, if the heart rate is low, you're going to make up for that, right? Because you don't want blood pressure to drop by increasing the systemic vascular resistance. And if you think about it, the neuroepinephrine is not only acting on the heart, but it's also acting on the peripheral vessel to cause vasoconstriction. So this patient didn't respond to neuroepinephrine, but did respond to atropine. And I would argue this is a very strong signal to me that the bradycardia, in fact, was driving the patient's hypotension. And Zachary, I think it's fair for us to ask, how low was the heart rate before atropine was given? Because bradycardia can mean 50, it can mean 20, it can mean 5.
So she went as low as 32, but sinus.
Got it. Okay, so that's a really important first branch point, because you want to put a value to the heart rate. Because if you told me someone's heart rate is 40, I'd be like, it's probably not driving their hypotension. And this is a young person, and a heart rate of 32, it's quite low, but I'm assuming she has a healthy heart. Of course, if she doesn't have a healthy heart, then you don't need much of a drop in heart rate for the blood pressure to plummet. Because you have other parameters that are perturbed, like the stroke volume, but maybe underlying myocardial disease. But here is the approach to bradycardia, and this is, you see, she definitely meets the definition, heart rate 30. And if we tie this symptom of hypotension, and you go down the ACLS algorithm, and the first part is actually atropine is what you did. And then if that doesn't work, there's dopamine, epinephrine, and pacing. I'm going to ask Robbie to think about why the norepinephrine didn't work. I'm struggling a bit with that, to be quite frank. And but you guys can see the rest of this figure. Just take a mental framework of that right here. And Robbie already mentioned, if you're sleeping or you're an athlete, many times in the hospital we see patients with a heart rate of 40 while they're asleep. You don't need to be worried about that. Like, they're sleeping. But in this patient, they're hypotensive, so I'm very worried. And already Zachariah told us that it's sinus brady, but you want to make sure that they're not dropping beats, et cetera. And then we have like a very simple framework for that. All right, so to summarize, I'm unable to reconcile why norepinephrine didn't work and why atropine is working. You know, Robbie, what I thought about is like patients with heart transplants, where you basically are effectively denervating them of the vagal nerve. Atropine doesn't work in that context. However, because there is no cholinergic response to block. But I would think that if you think about what receptors exist on the heart and on the vessels, they're beta receptors. And you would expect these agents to act and cause contractility. I feel like I've spoken for quite a bit, and I know that there was a preceding clinical syndrome prior to all this, which was admitted to ICU for a low GCS and a decline over 6 months. So it seems like the heart isn't the only issue here. It seems like this is a multi-system process that's involving the brain, maybe involving the muscles, and is also involving the conduction system. But Robert, let me give the mic to you. I felt like that was a little bit of a messy response, but to me, I guess to summarize, I think the improvement in blood pressure with atropine and the rise in the heart rate, it's almost like, you know, Whipple's triad for hypoglycemia. You get glucose, they get better, then, you know, the low glucose was the culprit. Here, the heart rate was low, we increased the heart rate and the blood pressure improved. That's not to say that other elements aren't perturbed, because there's a small pericardial effusion, but I would love to know what the heart is doing after the atropine and with the increase in heart rate.
You know, Professor, I'm right with you. It's hard not to feel discombobulated, because one, I've never seen this before, and so I'm relying on analogical reasoning to make progress here. And I think, you know, if you stick to like what the mechanism of atropine is, assuming that something that we don't know is working here, is you block parasympathetic tone and then you cure the patient of the very restricted problem you're focusing on. Of course, I think it seems that we have other problems to focus on. And so I think for me, that tells me, hey, I think that her syndrome is parasympathetically driven. And so I'm only taking it that far in my mind because of a piece of knowledge that I'm borrowing from a different world about carotid hypersensitivity. And if you study the landscape of carotid hypersensitivity, and the up-to-date article is a very good one, it divides it into two forms: a bradycardic hypersensitivity, where a patient's heart rate slows down, and then what's called a vasodepressor hypersensitivity, where a patient has a normal heart rate, but because of the vagus effect on the sympathetic tone and the parasympathetic tone on blood vessels, the patient gets a vasodilatory response and gets hypotensive without any changes in heart rate. So I think it's important to track the idea that the parasympathetic system can do two things at the same time. It can slow the heart rate and dilate the blood vessels. And depending on what kind of carotid hypersensitivity you have, you can get any mixture of those two things. And so for me, I'm not sure if this proves that the bradycardia is driving the hypotension. I think that's very possible. In parallel, I think it's also possible that she has high vagal tone that's simultaneously driving a low heart rate and vasodilation, which upon addressing that high vagal tone corrects the issue. I think this is an academic exercise, really, because I think what I would be doing in real life is to sort of ask myself, is this a definitive proof that the pathological driver is excess parasympathetic tone? And then I would ask myself, why the heck is a hospitalized patient having an increase in parasympathetic tone? Most patients in the hospital have the exact opposite problem, where they're so revved up from their problem. So I think the thing that's left for me on the table is, why is her EF low? Because a parasympathetic tone increase doesn't explain that. And then I'm going through my no miss checklist of why a patient would have a pathologically elevated vagal tone. This is the equivalent of vasovagal syncope. And that's another stretch, right? Most vasovagal syncope is as a result of an exogenous stimulus, like emotions or straining, that triggers the vagus nerve to go crazy. But this patient being intubated and sedated has no exogenous reason to have a vasovagal process. And so prompted by Mark's outstanding case of a small cell carcinoma causing mediastinal compression of the vagus nerve, causing a very similar syndrome to this patient, I'm now wondering, does this patient have an endogenous reason that's stimulating her vagus nerve? But all these, honestly, Prophet, all these are stretches, because it's a stretch that assumes that the response to atropine has a diagnostic value. And I'm only using that because it seems plausible, but what seems to be true based on the textbooks is rarely true in real life. So I'd be cautious about that line of reasoning. So I think I'd be pursuing everything in parallel, but I'd be intrigued by those possibilities for sure. Anything to add to that, Prof. Rez? Or like you, I'm wobbly right now. I think I need more data to feel comfortable.
I like putting that frame of like, could this be parasympathetic excess? But I wonder if the EF, like I don't know if you can really measure the EF when the heart rate is like 30. So I don't know if I would incorporate that into my framing. Like I'd be really curious to like what the repeat focus shows, and then not studying this in isolation and incorporating the preceding 6 months and the fact that the patient, you know, has had brain fog and brain failure prior to what seems to be conduction failure.
Professor, I have a quick story for you. When we were coming out of the car back home today, Nara could smell that Kara was here, but he couldn't quite tell which direction she had come from. So he was like sniffing around, sniffing, and like almost a full circle. And I feel just as confused as he is. I'm like, where is the disease? Is it this way? Is it over here? Is it over here? Is it over here? And hopefully after an alcohol or two, we'll catch on to the scent of where this problem is. But right now, I'm as discombobulated as Nara was this morning. Mike, to you, Zachariah. I'm laughing at my own joke. If you didn't laugh at it, you're a loss. It's a good one.
Incredible discussion, and I think just to answer the one question, that once the patient had been started on atropine and then on an infusion, she became tachycardic, but the repeat echo still showed that while she was tachycardic, her left ventricle was definitely not contracting well. So on her vitals, blood pressure was 75/40, her pulse was 32. That then improved with atropine. And just to reiterate, the patients on an adrenaline infusion as well, which had not made a difference in our heart rate. So in South Africa, just due to cost reasons, we don't often have access to norepinephrine in the public sector. Her respiratory rate was 18 and her oxygen saturations were 100% on room air. On general exam, her eyes appeared swollen bilaterally. She had no lymphadenopathy. She was quite pale and had no conjunctival icterus. cardiovascular exam revealed a bradycardia that then resolved. She had no peripheral edema. Her JVP wasn't raised, had a normal S1 and S2. And once she was tachycardic, she actually did have a positive gallop. So she had an S3. Her respiratory exam was completely normal. And I will say that she had no wheezes and no excessive secretions. Her abdominal exam was normal. Her CNS exam showed that she was quite agitated and her eyes were open, but she wasn't really able to understand us or follow commands, and she was intubated. Her pupils bilaterally were constricted, so about 1 to 2 millimeters, and sluggish to light bilaterally. In terms of her skin examination, she had no diaphoresis, and she had this diffuse rash over her upper back, torso in the front, and her arms and her hands, but there was nothing on her legs. Some of the rash you could actually feel when you touched it, and others just were macules that you couldn't feel. I can share a representative example of it, as unfortunately I was not able to get consent to take pictures of the patient. So this is pretty much what her rash looked like over pretty much her entire upper body from the pelvic region upwards. And I'll stop there.
This is so interesting, Zachary. Yeah, I think that the rash. Maybe I can dissect the rash and leave everything to you, Prof. Rez. I think the rash is very interesting here, and I think it gives you a sense. At least it gives me a sense that the disease isn't just a cardiogenic one. That there's something going on in a more widespread and systematic manner. And I think that the appearance, at least of this image, is suggestive of that, because at least in the top at that 11 o'clock position, there seems to be a nodular component to the rash, as Zachary emphasized. It could be palpated. I think most rashes in hospitalized critical care patients are often heat rashes or non-specific contact rashes, but I think the nodular appearance of this one is very interesting. I think my relative weakness in dermatology would push me to try to understand the internal landscape a little bit better and then come back to this. And I think we'll be able to get a lot more juice out of it when we understand the visceral problem better and reassess the rash. So I think for me, the rash is noted. I'm hoping it's not a distractor from a heat rash or a contact rash. I think the hint that it's not is the nodular distribution, the nodular features, which often imply a depth that emanates from the core of the body. The lack of their appearance on the legs is intriguing, but I'm putting that all aside because I think there's so much left to understand internally, and then I'll come back to this. Mike, to you, Prof. Rez.
Thank you, Robbie. Definitely, just so I guess I understand the timeline of stuff. She's had a progressive decline over 6 months. When exactly was she hospitalized and intubated, and is she still intubated?
So the patient had been admitted to us. So this was on day 1 in ICU. She'd been admitted to the hospital 2 days prior. So at this point, we still hadn't yet met her family. We're not able to really get a history of what's been happening beyond what I've already said in terms of the last 6 months, just that she'd been feeling unwell. I'm presenting this case sort of exactly as how we found it here.
No, I appreciate that. I think that's even helpful to know that that she hasn't been in the hospital for like weeks on weeks, where a lot of complications can ensue. And yeah, it's very fair, but just knowing the timeline, I think is quite helpful for all of us who are trying to solve this case. I think that as far as the rest of the exam, it's really hard when someone is intubated and sedated to get a good neurologic exam. And this can include the pupils as well. What's interesting here is that Zachariah told us that the eyes were swollen. And when the eyes are swollen, it can mean a few things. It could be that the patient has conjunctivitis, common things being common, that comes in forms of allergic, bacterial, and viral infection. It could be that the eyes are actually, they have something called chemosis, where they have swelling in them because you have underlying SVC syndrome. So if something is obstructing the SVC, the pressure builds upward and it causes the eyes to be swollen. However, sometimes swollen eyes are mistaken for proptosis, which can be consistent with thyroid disease and Graves' ophthalmopathy. So you have to make sure, like it makes a lot of, you make a lot of progress by knowing exactly where is the swelling, is it projection of the eye? If it's true swelling and it's true chemosis, then all of a sudden you worry about a high pressure, and that pressure could come by, for example, from a cavernous venous fistula, where you have a high pressure and you get chemotic, or as we mentioned, like SEC syndrome. I would send like a TSH. And as far as like the rest of the physical exam, there isn't, I mean, it's not that helpful that we're not detecting lymphadenopathy, because oftentimes lymphadenopathy hides underneath the surface. But really where I am in this case is a person who comes in with cardiovascular collapse from both conduction system pathology and myocardial pathology. That's really important to know, because when people have low EFs, the response of the body, if you go back to that equation, is actually increase the heart rate. So this disease is taking over not only the myocardium, but also the conduction system. This disease is invading the skin. This disease is causing something to the central nervous system that caused this person to be somnolent. So all of that being said, where would I take this? Well, of course, I'm gonna give the fluid, give the pressure, manage all of that. But I'm really looking for a multi-systemic infiltrative process. And would I be surprised if we get a CT scan and there's a mass that's invading the SVC, or there's stuff that's invading the orbits, and that the same stuff is invading the skin? No, I wouldn't be. And I don't think it's actually worth naming specific diagnoses just yet, because we're still trying to understand the lay of the land. But right now, I still feel pretty overwhelmed. All I'm listing in my mind is conduction disease, myocardial disease, skin disease, likely CNS disease, and then either something that's affecting the SVC or the cavernous venous vessel causing chemosis. Rabih, anything to layer upon that? I still am really struggling, and this is where history is really important. I think our job, at least at time point 0, is to stabilize the patient. Like, that's the only thing I'm concerned about for now. But as the days go on, then the HPI is going to be, I think, really helpful to understand the sequence of events.
Yeah, Prof. Reza, I'm right there with you. If there's anybody out there who knows which door to open, congrats to you. You're way, way, way ahead of me. I am still sampling and trying to figure out what's going on with the heme system, what's going on with the liver, what's going on in the lungs. As you said, Prof. Reza, right now, the biggest mistake to make is to pretend, unless you're a supernatural being, that you know where this is headed. And I think all too often we make the mistake, and it's called premature closure, of having an illusion of where the disease is. Right now, you have to calm, focus on the emergencies, as Prof. Rez said, and continue to survey the landscape. And when you have a clearer picture, is a time to start walking. Right now, Prof. Rez, I'm standing still and absorbing, just like you. And that's not bad. I think all too often we think that that's a bad thing, that's a sense of, and that creates a sense of discomfort. I think for me, I'm just trying to push myself to be comfortable in the fact that there is inherent discomfort right now. We've only known the patient for 10 minutes, right? In real life, we just corrected the blood pressure. We just noticed the rash. We don't even have labs yet. It hasn't even been an hour. So slow down. Let's not move too rashly. You get that, Prof. Rez? All right, Zachary, Mike to you.
So on to some further labs. So I'll start off with by saying that the patient's chemistry was pretty much normal: sodium, potassium, CMP. Renal function was normal. However, she had a urine protein to creatinine ratio that worked out to about 4 grams per day. Due to the fact that she had bradycardia, constricted pupils, might have seen an alternative practitioner, we empirically treated her for organophosphate poisoning with the atropine, and we sent off a pseudocholinesterase levels. We don't have the red cell cholinesterase level, which is usually a bit better. But that the one that we did send came back negative in that it was normal, and her urine tox screen was also negative. In terms of her liver enzymes, her LDH was 1,099. She had an elevated total protein with an albumin of 2.5 that was quite low. Her bilirubin was normal, AST 163, ALT 52. In terms of her inflammatory markers, initially her CRP was 15, and it rose to 75 the next day. I do also need to say that in terms of her vitals, when she came in, she was afebrile. She had an ESR of more than 100. And in terms of her FBC, she had a white cell count of 6.3 with a neutrophilic leukocytosis, and she was lymphopenic. Her platelets were 132, and her CD4 count was 288. Her HB was 10.3 with a normal MCV, and she had a normal serum iron, but a slightly low percentage saturation, and a ferritin of 2000. She had a B12 that was normal, a reticulocyte count that was normal, and coagulation studies were normal. You brought up her thyroid functions, and she had a slightly low T3, but the T4 was normal, and the TSH was also normal. She initially then had a BNP of 2000 that then rose to 4000. In terms of a couple of other tests that were done, she had a slightly low C3, but the C4 was normal. Her haptoglobin was normal, and a Coombs test was negative. And I'll stop there.
Once again, a lot of data, and it's easy to feel overwhelmed here, but I'm going to give you guys a tip to take that feeling away. And that's the following. As our scriber is catching up to all the data that Zachariah shared, the tip is this, is that even though there's a lot of data at us, focus on the ones that are most abnormal. So for example, like the BNP of 4,000, I don't care about that. Like this patient's EF is so low, they're not contracted. That's exactly what I would expect it to be. The AST and ALT, it can be helpful, but it's not that elevated. Out of all the information that Zachariah presented, the one that caught my attention the most, Robbie, was the LDH. Because when you have an LDH that's greater than, 1,000, it's signal. But here's the challenge with that too, is because this patient's hypotensive, so you just wonder if they've had any form of ischemia and any form of infarction of tissue. But I don't think they have, because if they really have like a shock liver, I would expect the AST and ALT to be in the thousands, not in the hundreds. So I'm gonna run with that thread of the LDA, and the lowest hanging fruit when LDH is elevated is to look at the hemoglobin and ask the question, is the patient having hemolysis? And here the hemoglobin is 10.3. It's a young person, so they can be compensating with reticulocytosis. And the AST and ALT, that ratio of 2 to 1 takes me beyond the liver, and hemolysis is another place that you can get that ratio. So at minimum, I would be getting a peripheral blood smear. I would be sending a haptoglobin level to make sure that that LDH is not coming from light red blood cells. Additionally, because this patient is intubated, is sedated, we're seeing a lot of stuff going on with their autonomic nervous system. I would be interested in a CK level to make sure that that CK is not elevated and this is not, a consequence of Bradville. But once you rule out the most common causes of LDH elevation being hemolysis or tissue infarction, then you're left at underlying malignancy, specifically liquid cancer over solid cancer. This patient is quite young, and lymphoma, you're starting to think of like multi-systemic entities. And lymphoma, you can have cutaneous forms of lymphoma, or you can have lymphoma that infiltrates the skin. So I think cross-sectional imaging is something we all want right now, and that would be of the chest, abdomen, and pelvis. For one, understand if there is any lymphadenopathy beneath the surface. To understand is that SBC obstructed? Additionally, I think we would all want an MRI, an MRV of the brain, just to see the venous system, because again, we're running with the signal of these enlarged eyes. But honestly, Robbie, I know we have like lymphopenia, a low CD4 count. I mean, we would send an HIV. I rarely get that CD4 count until I had like this lymphocyte subsets, until I have like an HIV that comes back positive, or I'm worried about a compromised immune system. So I'd be interested in Zachariah, what prompted sending the lymphocyte subset from the start. Oh, Robbie just texted me and oh, HIV positive. I understand. Okay, thank you. So that actually is such a thank you for letting me know, Robbie. That's so important because now all of a sudden we have an immunocompromised patient with this presentation and a high LDH, and these patients are at risk of opportunistic infections and malignancies. And now the possibility of a lymphoma that has spread and infiltrated multiple organs, at least in my mind, rises. I think the mistake to make here is to settle on one possible diagnosis. Being immunocompromised, the patient is at risk of multiple processes, meaning the skin can be one thing, the heart can be another thing, the CNS can be another thing. But let me just end with this before I pass the mic to Robbie. Right now, I think the problem we must explain at the end of all this is why is the heart not functioning properly? Why is the conduction system not functioning properly? I think as I list this stuff, like the test I would send, would, if you have the capabilities, would be a cardiac MRI with gadolinium, just to see if there's something that's causing delayed enhancement and suggestive of infiltration. We have to explain why is the brain not working properly. And this, an MRI would be really helpful here, but I would add the MRV of that venous system of the brain to see what's causing, you know, the chemosis or the swelling of the eyes. And then the skin, and like this, and maybe we get the answer to the skin by understanding what's happening within, but a simple biopsy of the skin may show what is actually infiltrating everywhere in this patient. But yeah, Robbie, I think like that LDH to me, there's not a strong signal for hemolysis. And I'm just worried about cell turnover. And I don't think it's necessarily hypotension leading to ischemia of tissue because we don't really have a shocked liver. So I'm just worried that there's like potentially other cells that are turning over in this patient who's immunocompromised.
I'm right there with you, Prof. Rez. I think we've caught the scent of this disease. And for me, I'm taking what you said and summarizing it to the fact that this patient is under high pressure. And I think the way that my mind is getting there is to analyze the LDH in a very simple way. Is LDH a laboratory-based issue or is it a radiographic issue? And I think in most instances, it can be in most instances it's a 50-50 split, be it an LDH from rhabdo, which is a laboratory issue, not a radiographic issue, or hemolysis, which is a laboratory issue, not a radiographic issue. But LDH can often signify a radiographic issue, and the radiographic issue it signifies is widespread tumor burden or widespread space-occupying infection like disseminated TB. And the reason I say this patient is under pressure is now we have so many pieces of evidence suggesting that there's something occupying space causing high pressure. And it not only is that evident in the fact that it's bursting through her skin, causing a nodular skin rash, but I think also now the compelling hypothesis of what Prof. Rez anticipated a long time ago, an infiltrative disease. And I now really, really worry, given the degree of obtundation and the fact that she has a systemic disease, that she has a systemic disease going to her brain. And I think the question really is, does she have a systemic disease going to her brain parenchyma? Or does she have a systemic disease going to her meninges? And I think that's the next key step. But for me now, Prof. Rez, the operating hypothesis is that she has a process that is space occupying, which will mean my pretest probability of the imaging being positive is very, very, very high. And I suspect the imaging to require a biopsy to reveal cancer, or we might get lucky and have a microbiological insight into what that imaging abnormality is. And so for me, I'm very, very suspicious that her imaging is going to be floridly positive. And if it's not, I know where the disease is. It's in her meninges. So if you tell me her CT scan shows blank, I'll be like, great, I'm going to pursue blank. If you tell me that the CT scan of the head, chest, abdomen, pelvis is negative, she has a meningeal infiltration for sure. And so the evidence for pressure is in her scan, and I think in her parasympathetic response. So I'm really, really curious to see what her imaging is, and I suspect that'll update our problem representation. If not, I think an LP is going to be really key. Yeah. All right, Zachary, very, very interesting case. Mike, to you.
Just an incredible discussion. I think to answer a couple of questions, she had a normal ECG with no features of ischemia, and the troponin was negative. She had a CK of 1,400 and a normal rheumatoid factor. I'm going to share her CT brain, chest, and abdomen, but just to say that unfortunately at the hospital that I work, we have one radiologist who reads all of the CTs for the entire province. So for most of our patients, we are unable to get reports. In this case, I'm sure there are probably abnormalities you will see on the imaging that might clue you into the diagnosis, but unfortunately, I don't have any interpretation to share with you. So I'm going to first share the CT brain post-contrast. I'll play it one more time, and then I'll play the CT chest and abdomen afterwards.
I'll take the head, Prof. I think there's no evidence of herniation, hydrocephalus, or hemorrhage. I've always wanted to say that out loud. And I don't see any large intracranial lesions, any obvious asymmetry on a quick glance.
That's what we felt as well. And then this is her CT chest and abdomen. I think I'll stop there. There's not much more to share on that unless you'd like me to replay anything. I think before you continue discussing, I'd just like to add a couple of things in terms of the workup. So after the CT was done, we did a lumbar puncture that showed a markedly low glucose. She had more than 10,000 neutrophils, only 4 lymphocytes. She had a negative CSF gram stain culture, India ink stain, serum cryptococcal antigen was negative, and the viral panel on her CSF was also negative. She had negative syphilis studies, negative hepatitis, negative CMV, and negative EBV. And I'm not going to have any tricks up my sleeve. This patient had an extensive TB workup that was negative. So sputum gene expert negative, CSF gene expert negative. We did the urine lamb, even though it has a relatively low use in somebody with a high CD4 count, well, a relatively high CD4 count, but that was also negative. And I'll stop there.
Go for it, Robbie.
Oh, Prof. Rez, yeah, I'll just, maybe I can just share my reflex on the CT and then pass the mic to you for the rest of the stuff. So on the CT, it was actually difficult to discern. I don't think I caught anything in the lung windows. I thought the liver was a little bit enlarged. The thing that I'm most confident about was I think there was a decent amount of mediastinal lymphadenopathy and retroperitoneal lymphadenopathy, but lymphadenopathy is very, very difficult to detect. I often need to zoom up and down for it. But I didn't see any a large pericardial effusion. I didn't see evidence of bowel disease, kidney disease, pancreatic disease. I was looking for the spleen. I look for splenomegaly on the sagittal view. I'm not so good at it on the axial view, but I didn't think it was very large. So all that I could ascertain if I were in Zacharias' position, having to do the best I could with the read, is that I think there's a lot of lymphadenopathy.
Zachary, was that what you guys felt too? Because that would be helpful to know people would interpret CSF.
Yeah, so I think for us, we thought perhaps the liver did look a bit enlarged, and that she had a small pleural effusion, very mild pericardial effusion, but we couldn't really get much more than that from our interpretation.
Very, very helpful. I think here, you know, the CSF is striking. And what's so striking about the CSF is two parts of it. One is the very, very low glucose. And the way to assess what the glucose in the CSF should be is just compare it to the glucose in the serum. So if someone has really high glucose in the serum, they're going to have a higher glucose in the CSF. If they have low glucose in the serum, it's going to be lower. There's some kind of ratio that I'm not recalling. When you have a glucose less than 10, what does that tell you? Something is consuming the sugar. And oftentimes, when the glucose is that low, it can indicate an infectious process, specifically TB or fungal infection, that is just overtaking and overwhelming glucose consumption. But you can imagine even cancer cells being in the CSF can lead to a low glucose. I don't have the best DBX for it, but it's something that would make it into the palm representation and would serve as a signal to understanding what is wreaking havoc on this young lady. The really high neutrophil count, oftentimes we see with bacterial meningitis. And here, like Robbie had suspected, that the parenchyma, if normal, that the meninges would demonstrate evidence of inflammation. And when you have white cell count that is that high, it tells you for sure you're having an inflammatory process. But the neutrophil count, I think you said was 10,000, if I'm not mistaken. That's just so high, you know, and I'm sure that also is probably going to be a strong hint to the final diagnosis. But what my mind takes from all this is, as we mentioned, is an infiltrative process that is invading the meninges, that is invading the skin, that is likely invading the myocardium, and probably also the conduction system. And when you get to that sort of infiltrative bucket, the diagnoses we should all consider includes granulomatous diseases. It includes histiocytic diseases that infiltrate. It includes IgG4 related disease. But in this context, with the very low glucose, I'm just worried it's either a disseminated fungal infection, and you can get a high, if there's like small abscesses that you're not seeing near the meninges, you can get a really high neutrophil count in the CSF as well. So I would prioritize two buckets of diseases here. One is an atypical infection like TB or its cousins like fungi that are endemic to a specific region that's going everywhere and explaining all this, or an infiltrative malignancy, specifically like a lymphoma that is going everywhere and causing all this. I can't really take it beyond that, Robbie, to be honest, but would love to know if that very low glucose, that high neutrophil count, if it ends up suggesting a specific diagnosis in your mind.
No, Rafras, not at all. I think that the diagnostic path is to rely heavily on the microlab first, and then potentially the path lab for flow cytometry or any tissue you can get. I think the question facing you in real life is, would you institute empiric treatment while you wait for that information? And I think for me, knowing the prevalence of TB where Zachariah lives, I think I probably would. I think the question with the excellent point that you brought out about the dimorphic fungi is, would I empirically treat for them? I think I would too. I think the patient's risk profile for serious consequences is so much higher than the risk of these medication toxicities that if I were alone making these decisions, I think diagnostically I know what to do. Micro and then path, ideally in parallel. The chances that this person doesn't have a concrete diagnosis is very low. This is too hectic and too crazy. So the real question is, should we empirically treat them? I think I would. I'm curious what you would do, Prof.
You know, Robbie, I was just looking at my notes, and Aaron Berkowitz's textbook, he has a line that says, a CSF less than 18 is strongly predictive of bacterial meningitis. We know it's not the case here, though it can also occur in mycobacterial, treponema, and fungal CNS infection. So I mean, the rash isn't consistent with syphilis, but definitely I think it's worth sending an RPR in someone with HIV in this presentation. As far as what would I do treatment-wise, man, honestly, I would get ID involved to guide those steps of empiric, antifungal, antimicrobial. If I was somewhere where I didn't have an infectious disease consultant, based on that one line, I would empirically treat for both, just given how sick this patient is. But I feel like that glucose of 10 has to be a very powerful clue to the final diagnosis of either mycobacterial, fungal, or treponema disease.
I'm right there with you. I just want to acknowledge honestly that even though I'm open to this being cancer, the degree of neutrophilia and the degree of hypoglycemia would have me learn a precious lesson about what subset of cancers can do this. This is way, for those of you who are beginning your journey about learning interpretation of LP, this is way more consistent with a bonkers infection. Prof. Rez presented to me a case of a patient who had a solid cancer that caused a pleural fluid neutrophilia. I forget what that cancer was, Prof. Rez. So this can happen with cancer, but I think if you're really investing heavily, you'd invest heavily in infections, as Prof. Rez said, mycobacterial or fungal, or syphilis, apparently. I didn't know that. Zachariah, mic to you.
Wonderful. I initially actually intended to have one final aliquot, but I think it'd be a bit more useful if I shorten it and make it two short aliquots. The sixth aliquot is actually just going to be 2 lines. The first is ANA came back at 1 to 160, and 2, her blood cultures grew 2 out of 2 positive for Streptococcus capitis, and I'll stop there.
ANA, don't care. Blood cultures care a lot. I don't know about strep capitis, Zachariah. I think I'd assume it's a pathogenic organism. I would assume it's a non-hemolytic strep, probably oropharyngeal flora. It gives you a very powerful and very interesting diagnostic maneuver now, because all of a sudden you're in the world of bacteremia, possibly endocarditis, possibly shower of emboli. The question is, does strep capitis cause a meningitis? And I would say, based on the general behavior of strep, the answer is absolutely yes. Does it push me to reanalyze this entire case? The answer is partially. I think that this whole case is contingent on the time course of the disease process. And I think all along in our mind, we were trying to figure out why this patient had a subacute decline. But if it turns out that she had a subacute decline punctuated by a severe acute disease, then this case might coalesce to her having a streptococcal meningitis. I know that we've had cases of streptococcal meningitis from strep suis, for example, in Vietnam. I don't know if this is the South African equivalent of that, so I'd be very curious. But if you just take this case at face value, you have a profile, as Prof. Rez, that's very consistent with acute bacterial meningitis. So this case might just be that a patient with HIV is immunocompromised, and the most common infection that patients with HIV get are actually regular old infections, but they get them in a much more severe manner. And so I think this somewhat unexpected result is fascinating. And I think it's unexpected because the lead we were pursuing is maybe completely erroneous, that she has a subacute decline unrelated to her fulminant presentation today. So what would I do next? I think I probably wouldn't change our management immediately, because the coverage that we'd have empirically for a critically ill patient like this would probably capture this organism. I think you might consider getting an echo and just reading a little bit more about this organism. It's not something I know much about. And I'd be really curious what the CSF cultures grow, because the gram stain didn't show it, but the cultures may. Any other thoughts, Prof. Rez? All right. Oh, and do a good mouth exam. She's intubated now, so it's harder, but make sure she doesn't have any dental abscesses or things like that. Or review your CT head, because that'll get you a good tooth. I didn't look for the teeth, Zachary, on the CT head. My bad. I'd probably go look back at that.
So what happened to the patient was due to the classic CSF, she was started on ceftriaxone. We don't actually have much vancomycin-resistant Streptococcus pneumonia in South Africa, so we usually don't use it at the start. She was started on ceftriaxone and high-dose steroids. And the next day, her rash had made and actually a remarkable recovery. In terms of just a little bit more labs, she had negative ANCA serologies, negative anti-phospholipid antibodies, but she had strongly positive anti-double Smith DNA and anti-double-stranded DNA and anti-Smith antibodies, strongly positive anti-SSA and SSB antibodies, positive anti-ribosomal antibodies. And in terms of a myositis panel, her anti-Rho52 antibody was positive as well. And I'll stop there.
Maybe you could keep going, Zachary. So I'm just having difficult, like, that's yelling lupus, young woman with a very specific antibody. We have to be cautious in someone with HIV who might not have good immune response. Their antibodies may be falsely negative, but obviously here we're having positive antibodies. But I would love to know, like, so she has HIV, she has lupus, she has this bacterial infection. Yeah, it's just a lot for me to process and understand how all this is coalescing into her current presentation. Like, I would have never thought, like, I'm trying to understand why the LDH is elevated. I'm still trying to understand why the heart function is down, like the EF, unless it's just sepsis and just stress-induced cardiomyopathy. Why did she respond to atropine? There's so many question marks in my mind. I believe all this data, by the way. I'm not questioning the data one bit. I'm questioning my ability to synthesize it into a coherent story that matches the knowledge base that I have. But this is way beyond my knowledge base. Robin, do you have a way of, like, I could say this is lupus, I could say, yeah, it's bacteremia, I could say this is HIV, but I can't really create like a nice coherent, explanation for everything.
Professor, I think the truth is that if you're walking into a situation where you don't know what the patient has, and you see that she's bradycardic and hypotensive, and you ultimately walk out of the situation with HIV, syphilis, bacteremia, and lupus, bacteremia, and bacteremic meningitis, you probably can't walk out of it in a straight line. And I think, as I was sharing with folks in the academy, I think for me, this is a slam dunk case of lupus because of the specificity of the antibody profile, the hypocomplementemia, the proteinuria, and the age and gender of this patient. It's a slam dunk case of bacteremia because 2 out of 2 positive for an organism. So those are incontrovertible. And I think the question that I'm grasping is, why is it presenting in this way? I don't know about, I'm really curious to read later about what the rates of autoimmune diseases like lupus are in patients with HIV. I'm very, very curious about that. Because in general, I think whenever we think HIV plus disease, we think prioritize infections and cancers and underwhelm autoimmunity. But is the rate of autoimmunity just the base rate of the population, which she still is, or is it actually higher or lower? So that's a big knowledge gap. But I think for me, this is a conversation that we were having in the academy about the third person in the room. And the third person in the room with you and the patient is the relationship that the patient has with society and with herself. And I think that this is an incredibly unusual presentation. And I think it partly might be unusual because the textbooks that you and I have read and we continue to read, Prof. Rez, are for people who present to healthcare sooner or have higher access to resources. I think very, very few patients with lupus are diagnosed with lupus in this manner. And I think when all these things merge together, it creates a very cloudy, discombobulating picture. But ultimately, an opportunity for all of us to push ourselves to the next level. And this case definitely overwhelmed me in fake life, let alone being Zachary, having to interpret my own radiology and figure out what to do next. I mean, massive, massive kudos to you. But I'm very grateful for the rep here. It's left me with a little bit of vertigo, but hopefully less vertigo when I actually take care of a patient like this. Mike, to you, my friend.
Sure. There's so much to actually discuss. I know we're a bit over time, but I think first I actually felt bad because I can see I was making you a little bit dizzy at times. So this patient, I actually withheld it because I didn't want it to focus on more bread and butter things like bacterial meningitis, like hypotension, bradycardia. But when we first saw this patient and she was hypotensive, on examination, if you go to a textbook of rheumatology and you look for dermatomyositis, you can take the pictures out of that and remove it because this patient had better pictures of dermatomyositis. It was as classic as could be: heliotrope rash, Gottrin's papules, and so on. So even though we didn't have any history at the time, we got it later on that she'd been actually struggling to walk over the last 6 months and she'd been actually having some dysphagia. We strongly suspected that she had dermatomyositis at that time. She seemed to have a mixed autoimmune disease with lupus as well, Sjogren. She started to have some tubular wasting in her kidneys. And due to the prominent myocardial involvement and the fact that she was septic, we discussed her with one of the rheumatology professors about a couple of hours away from us, and we did give her a 5-day course of IVIG. There was actually a reason I asked Jeffrey if he'd be able to join today, because I'm sure he might have some things to add, but that was where we were at. It was actually useful that in this case, because of bacterial meningitis, we had every indication to treat the patient with dexamethasone, which also made an absolutely astonishing difference to her rash. It basically disappeared within 24 hours to the vast majority of her cutaneous features. And I think that's also what caused her CK to start to go down and her cardiac function to improve a bit. Yeah, and I'll stop there.
Can I just say one thing? First of all, Zachary, I want to applaud you, and I think everyone should applaud you because the way you presented this complicated case and the fact that you walked us through all the images and the fact that you probably stretched me more than I've ever been stretched before in a live setting. Usually I get this feeling when I'm reading a NAGEM case on some weird topic where I'm like, oh man, whatever. Let's just move on to what the expert says. But here, supposedly, we are the experts, me and Robbie. So I want to just really thank you for that. And Robbie, you know where our lesion was, where my lesion was in my thinking and synthesis of this case? Like, if I could just tell you the main thing, it was looking at like that sort of subacute decline and assuming that subacute decline was what was happening today. Meaning, when we went to the CMS, we were like, oh, it must be a subacute, indolent, infectious process that now is overwhelming the system, as opposed to saying that, hey, could that subacute decline be something that's related, but not directly the same process? Meaning it's not a TB that's brewing in the background and then overtakes the system, but rather it's lupus in the background for 6 months. It's dermatomyositis. And then because of the HIV gets it, we didn't even say bacterial meningitis. Can you believe, like, I had to look at Aaron's one-liner to be like, oh, it says bacterial meningitis, but I don't think it's this, because my mind was trying to explain everything from the beginning to the end, as opposed to thinking about the multiple. So this is for me, this emphasizes that specific point more so than any case we've done. And it goes against the grain. And I think that's why I struggled with this case. Not only the overwhelming data, but what was happening prior may be related, but it's not the same thing that's happening today with that meningitis.
Yeah, Prophet, I think that's very, very wise. To be honest with you, I think this may be a little bit of ego talking and I think a sense of self-preservation. But for me, I actually, honestly, very frank with you, and it's cool to be this frank with you live. I don't have any regrets. I think that The reason I don't have any regrets is the following: is I think that when you're trying, the major mistake I think we made is we literally broke the advice that we shared with people, which is don't try to force yourself in a specific pathway and the problem isn't clear. And then when we just basically did that, I think I was just assuming based on time that Zachariah had was his final output, but I'm glad he had two huge, amazing, really rich educational surprises for us. Because I think in real life nobody would ever let you say don't get an ANA in somebody who is 25 who has proteinuria 4 grams per day and has hypocomplementemia. I mean, I think that would be a reflex test, and then when the ANA comes back, you would reassess the case completely. I think nobody diagnoses a bacterial meningitis without getting a blood culture, and when that data comes back, you would reassess completely. And so it was an interesting thing to try to force a diagnosis at that juncture of assuming the time course and whatnot, in the absence of those data points that you need to be able to actually formulate the case. And you have to know the results of the blood cultures to diagnose TB or endemic mycosis meningitis. And so it's a really cool thing to try to push yourself to come up with diagnostic clarity. But I think it ultimately shows you that when you're trying to close the door and you haven't received or processed the whole information, you're going to make a mistake. And so the question I'm asking is, in real life, would I have gotten an ANA in this patient? And after Zachariah's beautiful description of the rash and the workup of the nephrotic syndrome or the almost nephrotic syndrome, I think that's routine. Would I have gotten blood cultures in the patient? Absolutely, of course. And so in real life, I don't think I'd have any regrets. And I think in real life, this would just be a really humbling case of these kinds of conditions. And I would be doing a lot of learning afterwards, but I don't think that there is any major misstep or knowledge gaps or anything. It's just a beautiful story that's tragic for the patient, but a beautiful medical illustration that evolved in a way that is incredibly powerful and illuminating. And I'm really, really glad Zachariah did justice to that by showing us just how much he sweat. So for me, I'm having a great time. Learned a lot. No regrets, and very, very excited to learn more the next time, to be honest with you.
I think just one more thing I want to add before Eugene. I know we're quite over time, but I'm sure there's some queries about why the patient had basically vagal toxicity. And the truth is, we're not actually sure, but one hypothesis is she had bacterial meningoencephalitis severe enough to make her altered. She might have developed a degree of raised intracranial pressure. And that causes bradycardia. But the reason she wasn't hypertensive is that she has myocarditis and her heart contract as well. So when she became bradycardic, she actually will become hypotensive. Why her pupils were not dilated but constricted, again, it's difficult to say, but she's on opioids and there were like other confounding things as well. So yeah, like the triad of Cushing's reflex, often you don't need all three, but that's our one hypothesis, and that might explain why the steroids helped as well. Her pupils got better, and the bradycardia and hypotension didn't return even once her atropine had been stopped. Yeah, that was the last thing I have to say.
I think we'll remember this case for a lifetime, and yeah, I will. Who knows if I'll show up to the academy session later today? Still thinking about this case, but why don't we hand the mic to Eugene, who has the unenviable task of trying to summarize all the learning in this case. Mic to you, Eugene.
Yeah, so this was a very complex case of a 27-year-old HIV positive patient who was already having a 6 months progressive disease. Eventually, we came to understand the clinical scenario tied to the labs that this patient was in an immunocompromised state and was prone to infections, bacteremia, S. capitis, strep capitis that possibly led to meningitis, also involving the heart. But there are multiple things that we could learn out of this, although we couldn't really have the clear pathway that leads to SLE diagnosis. We realized that from the onset, this patient has sinus bradycardia and hypotension. And the thoughts there was that, could this be an underlying clinical disease that is driving both sinus bradycardia and hypotension? Or could the bradycardia be the cause of the hypotension? And so when you're thinking around person with two of these issues, you shouldn't look at just and the state of distributive shock only. You could be considering an infiltrative disease. Could it be a conduction system disease? Could it be just high vagal tone, so just a parasympathetic surge? Or could it be drug toxicity? Or could it be just at the level of the AV, so a heart block? And when we saw the response to atropine versus norepinephrine, we started entertaining the idea that, okay, this could be a high vagal tone that may be driving hypotension. And Dr. Rabih mentioned about exogenous and endogenous causes. And then reflected on, Prof. Rez reflected on the exam findings where we could consider multiple issues causing the bilateral periorbital edema. That could be from a venous obstruction, that's at the SVC level, or thyroid disease, renal, or even cavernous sinus disease, or just an infiltrative disease that could be granulomatous disease or histocytic or even a lymphoma. And then the pupil constrictions, we couldn't really look deep into that because of the possibility that this patient is already intubated and also in the ICU. So you couldn't really rely on pupillary constriction, but that could also be pointing to a brainstem lesion. And then the complex nodular skin rashes, CNS fingerprints, cardiac, we just started entertaining a multisystemic infiltrative disease involving CNS, brain parenchyma, or meninges. And Dr. Rabih mentioned that if we looked at the CT scan and we're not really seeing any space occupying lesion, we could consider the meninges as a cause. And in fact, the CSF picture brought up a bacterial meningitis. And for some reason, I didn't really catch that bit, but for some reason, A&E was done. And we also did the antibodies for lupus, and it brought out the picture that this patient had an underlying immunocompromised state that flared up with this issues of hypotension, brain issues, and then bacteremia. Yeah, so that's where I will end with this very complex case, case that would forever stick in my brain. Thank you.
I have to say that I think Zachariah is on a different level and presenting this complicated case. After such a difficult case, all you want is a voice of Eugene. Eugene, I want to just literally put that by my bed and go to sleep right now. Your voice is so soothing. Your teaching points so concise, and for you to extract that diamond out of all the garbage that Robbie and I spoke of today. Robbie, I was thinking, why were a subset of us lymphocyte set, and Robbie said, he's like, dude, the patient has HIV. And then Robbie was giving the patient interference, and one boy had mycobacterial treatment. Robbie, sign us out.
I can't sign you out with my I'm so grateful for you all. It's so cool to be able to share this space with everybody and to live the pain and anxiety that Zachariah had. And Zachariah, one final question for you. How did she do? What happened? What was the ultimate outcome for her?
She did relatively well in terms. So she became better, then became septic again. Had to be started in meropenem, recovered from that. Eventually was discharged from ICU, but hadn't really neurologically improved. I actually found out today that she's still in the ward, and she's now starting to try to be able to speak and sitting up and so on. So it seemed like she took quite a hit to her brain, but there's been some slow recovery with time.
Yeah, I mean, the recovery from bacterial meningitis alone, let alone HIV, and wow, what an incredible case. Thank you so much. I don't know if I will emerge from my reading today, but if I do, I look forward to seeing all of you later. Bye.